allow me to introduce you to our moderator, Dr. Roshini Raj, who is a medical editor for Health Magazine, and she's going to be leading the session on health equity going beyond diverse clinical trials. Dr. Raj, I'll turn it over to you to introduce our esteemed panelists.
Thank you. Thank you so much. And hello, everyone. So excited to be here with my esteemed panelists and talk about this incredibly important topic going beyond diverse clinical trials. Just want to give you a very brief background on myself, and then we're going to hear from our two panelists. I am a practicing gastroenterologist and associate professor of medicine at NYU School of Medicine in New York City, which is why I'm wearing two sweaters today. It's quite cold these days here in New York. In addition to that, I'm a medical wellness expert and the editor for Health Magazine, the medical editor, as well as an entrepreneur. I have a skincare line called Tula Skincare. So I, in my daily 3 different careers, think about these issues of health equity in a lot of different ways, and really excited to hear other voices and have a really robust discussion this evening for the next about 40 minutes. So without further ado, I want to introduce my two panelists. And today we're joined and very honored to be joined by Dr. Mary Ann Etiebet and Dr. Leo Morales. Both have incredible pedigrees and backgrounds, which you're going to hear about right now, and which show really how well they are sort of credentialed to be having this discussion. So Mary Ann, maybe we'll start with you. If you could just give us a little bit about your background.
Thank you so much, Roshini. So, my background, I've been at Merck now for 5 years. First of all, leading our Merck for Mothers program. And for those of you who don't know about Merck for Mothers, about 10 years ago, our company made a $500 million commitment to helping end maternal mortality and eliminate the disparities that we see in maternal health outcomes. And based on that work, I now have the privilege of working with colleagues across our company as AVP of Health Equity to make sure that health equity is embedded in the day-to-day of our business strategies, our business plans, and what we do. And it's been, an amazing privilege and opportunity to do so.
Thank you so much. Dr. Morales?
Hi, welcome, and thank you for inviting me to join this panel. So I'm a professor of medicine at the University of Washington, and I have a couple of other hats I wear here. One is I co-direct the Latino Center for Health, which is a multidisciplinary, state-funded research policy and practice center in the health sciences. And then I also serve as an assistant dean for Equity, Diversity, and Inclusion with the Office for Healthcare Equity for UW Medicine. So it's really great to be here. I'm looking forward to the conversation.
Wonderful, thank you. Well, just hearing both of you, your backgrounds, obviously the issues around health equity have been part of your career for many years and part of your consciousness. But I think, these issues became really even more to the forefront for a lot of us and the general public in general around the time of the pandemic, which unfortunately we are still going through today, but really highlighting some of these major disparities in almost every aspect of healthcare, from access to diagnosis to treatment to outcomes. And would love to first hear from both of you, and maybe we'll start with you, Dr. Morales, kind of how the COVID pandemic has shifted, and if it has, some of the ways you're thinking about these issues of health equity.
Yeah, well, thank you. So I've been pretty much engaged with the pandemic since its beginnings. And very early on, it was clear that, we were going to have health equity issues arise from the way that the pandemic was being addressed as early as testing, how testing was being rolled out, and subsequently the vaccines. And so I think the clearest thing I've learned is there are huge gaps in our healthcare system and our public health system. There are large, in particular, when we've looked at Latino communities in our state, that are just not engaged are not, they're not reached. They lack access to care, and really lack the kinds of channels of information that are necessary to make good choices about how to stay healthy. I think one of the most telling patterns that we've seen is, very early on in the state, we were one of the first states to see COVID, and one of the first states to implement stay-at-home orders. What we saw is that the COVID infection rate did not slow or even stop climbing throughout the period of time that stay-at-home was implemented among Latinos and also among Native Hawaiians and other Pacific Islanders. It really wasn't until after those orders were lifted, because the general curve had started to come down, that there started to be some kind of decline in these two population groups. I think that speaks to the nature of the disparities in, for example, occupational exposures and exposures at home through multi-generational households. So I think the lesson for me is, we have a lot of work to do. Our work has been in community, and I think we need to continue to do that work, because COVID is not the end, or the beginning or the end of the health disparities these communities face.
Absolutely. That's really interesting about the statistics you're talking about with the Latino communities not going down. That's really fascinating. Dr. Etiebet, how about you? Did this pandemic change the way you thought about these issues?
Yes, and Marianne is fine. I think this pandemic, I think about health disparities as the hidden pandemic. You mentioned we're 2 years into COVID. We are centuries into, the pandemic of health inequity. But one of the things that COVID did do, was, I think, open all of our eyes, to the inequities that people were experiencing and have been experiencing, as Leo mentioned, every day. And so, the question I think for all of us is now that our eyes are opened, what are we going to do about it? And how do we make sure that we continue to raise consciousness, raise awareness, of what's happening, in healthcare and around access, to healthcare post, the COVID pandemic. The other thing I'd like to say, and I think this is following up on Leo's point, is, sometimes when people think, about healthcare inequities, they're just thinking about the health system. They're just thinking about, whether it's access to healthcare or the type and quality of care that they're receiving. But the other thing COVID did was really have people understand on a very visceral and oftentimes personal level, the social determinants of health. And how that is a huge factor in the disparities that we see. So whether it's where you live, where you work, whether you have access to daycare, all of those things that impact your ability to engage in health-seeking behaviors and receive healthcare. We understood that. Because we all experienced many of those social determinants of health barriers and are still experiencing them due to the pandemic. And, my hope is now that we kind of have walked, in the shoes that, that many people have been walking in for decades, and we've understand a little bit, what some of that experience is. We can all now, work together, to actually solve, for some of these systemic issues that are still with us.
Absolutely. And that kind of is a perfect segue to my next question, because you raised this issue of barriers. And, what do you see as some of the major barriers and also enablers? And who should we be holding accountable in terms of addressing these barriers? And of course, we'd love to hear some of the work both of you are doing on these fronts in your various careers. But first, where do you see the major barriers lying, and who should we, I don't want to say blame, but who do we need to kind of hold their feet to the fire to address them? Marianne, I'll start with you.
Go ahead.
Thank you. I think about the barriers happening in three different ways. So one, how do we make sure that medical care innovations, get to people who need them? And there are lots of things, that we've done at Merck, collaborations, to make sure that there's greater and more equitable access, to our medicines. So that's number one. Number two is how do we make sure that health systems actually work for people and deliver, more equitable health outcomes, for more diverse and inclusive, populations. And so, again, lots of collaborations around whether it's improving quality of healthcare, whether it's investing in the pipeline, so we have a more diverse healthcare workforce, which makes a big difference. And then the third thing is, how do we support individuals, as they are going through their healthcare journey? I think, Leo, you were the one who mentioned, it starts about, raising awareness and education. How do we make sure that people have the information they need, to seek the right care at the right time and make those right decisions? And we need to think about new ways, in order to reach out to communities and people that we haven't reached before. It's not enough just to put out information and then, you throw something at the wall and you hope it sticks. We have to go the extra step and really make sure that folks are understanding it and are able to actually act on it.
Leo?
Yeah, I think the one thing we should absolutely say is that when we're talking about racial ethnic disparities, we're talking about racism and long-standing racism that has created these inequalities that we see in the social determinants of health. So how is it that we end up having such maldistribution of those goods and benefits of society that lead to good health? Well, I think we know now, and we need to definitely work on becoming anti-racist in all of our institutions and in our research as well. The kinds of barriers that I see in the Latino community have, some of them are just being disconnected from a healthcare system, so no usual source of care or culture of accessing care when there are health problems. The culture is more like you stay away until you absolutely have to go, but this idea of preventive care is just not part of the daily life of most of many of Latinos. And it is a very diverse community, so it's important to make sure that I don't make these sort of general statements. The other sorts of things, of course, are language. So we have a scarcity of bilingual, bicultural healthcare providers, and that includes frontline staff. So very importantly, early on in the pandemic, doing outreach in community was difficult because many of the healthcare systems, our healthcare system and others in the state, just don't have the person power, that can do the outreach in the community. So I think those are important factors, as well as the ability to stay home during this pandemic and work from home and protect oneself. I'll just say one of the at-risk groups that was first addressed was healthcare providers. Yet the risk of infection was relatively low among healthcare providers and much, much higher among frontline and essential workers. And so I think, that was the beginning of an inequity that has persisted to this day.
I'd love to follow up on something you mentioned, Leo, and that's the impact of systemic racism on what the healthcare system that we have right now, including the people that are powering that health system, and the impact that has had on the trust of the health system, by many communities. And so one of the things that we need to figure out how to do is build back that trust, so that people feel comfortable using, healthcare services.
Absolutely, and trust was something I wanted to really bring up. So how do we build back that trust? Like you said, for centuries has been kind of eroded by racism and inequality.
Well, I think, it's, first of all, it's honesty and being able to hold hard truths and speak hard truths and acknowledge, all of our, all of our involvement and contributions, to the world that we live in right now. I think the other thing that has really been important in some of the work that we've done is consistency. So we're not just there, when we need something or want something or in an emergency situation, but we are with communities, from the beginning, and we stay, to the end. That continuity and consistency of collaboration, is so important. And I think the other thing is being humble and vulnerable and being open to change. Being curious. We need to. I think sometimes, especially us in the healthcare system, step out of our thinking of ourselves as experts, and knowing, what the answer may be. We have to ask questions, be curious, listen, and then act on what we are hearing.
Absolutely, yeah. Yeah, I think the one thing I've learned in the pandemic is that we have to be present in communities. And the reason we've been able to do what little work we've been able to do is because of partnerships with community-based organizations that have the trust. Yeah. And how did they get the trust? Well, they've been there a long time. And so they already have gained the trust. And so, we can't just walk in and be expected to be trusted or understood or, have impact. So I think we need to learn from the community-based organizations that are there and partner with them in real ways that bring support to them. So the other thing I would mention is community-based organizations have been asked to do a lot during this pandemic without a lot of the resources. So much of the resources that have gone to the pandemic go through large institutions like the university I'm at or healthcare organizations, not the smaller grassroots CBOs that really have the trust and access to the communities that are most in need.
Fully agree with that. We saw that with so many of the community-based organizations, for example, that we work with, through the Merck for Mothers, initiative. And Leo, as you said, they were also being impacted, by the community, by the COVID pandemic. But they were in those communities. They were still linked, to people that needed the information, needed the services, and that's the way we were able to get through, through it together.
Interesting. I'm interested, Marianne, because that sounds like that's global work that you're doing there with Merck for Mothers. If there are any models that you've seen that you think we can learn from in terms of health equity and kind of advice that we can sort of glean from other models of healthcare around the world.
Yeah, no, I think that's a great question that you asked. One of the things we have learned from the pandemic is that while it's affected all of us, it's affected all of us in different ways. And thus, while the, kind of broadly, the solutions, are similar, they look different, in different communities. I think my major learning, when I look at work that we've done both in the United States as well as outside of the United States, where health systems may not be, as sophisticated, or as strong, is that you need to be connected to the community, and those links, actually need to be powered by the community. And those links, we've seen digital, for example, take off, in terms of being able to provide information as well as understand, what people, have been experiencing. But one of the things we've seen is that, that access to digital technologies, is also something that we know is another social determinant of health. And so we need to make sure that our solutions don't actually exacerbate, the inequality, but we're intentional about how we apply them and how we work cross-sectorally, with other types of industry sectors to solve for these gaps.
Interesting. And you both work at large institutions, very different institutions, but both very large. And you're doing individually very important work. What has to go on internally within the institution to allow your work to be fruitful and to make all of this not just a moment in time, but a movement? So maybe Leo, I'll start with you.
Well, that's a big question. I have to say, I'm quite grateful I've had the opportunity to do the work I've been able to do, because I've been given the freedom to sort of explore all these different approaches, really. And I think for a lot of people, I don't know that they have that option. So I feel like we've had support personally from my own institution, and I think there's others that feel similarly. So I think this is the model we need, right? So we need to have people who are focused on centering communities and are working to establish those partnerships and finding ways to be helpful. And that's essentially what we've done. We've connected resources to community-based organizations as a way to address the pandemic. We have a certain skill set, and we can, articulate the need, and we can connect with, government officials or public health departments more easily. And it's really, we've been just bringing those resources to community-based organizations with whom we've had relationships for a number of years. And I think that's what large institutions need to have. They need to have ongoing presence in between and during projects. And one thing I wanted to mention is, the current funding paradigm for research is really project oriented, but that leaves out this continuity, which is necessary. So as I think Marianne previously stated, you can't just show up when you have a project. You have to be there all along. And that's the role of the institution, to invest in those relationships. And then it's more comprehensible to a community about spending, investing themselves in a research project, for example.
Like Leo said, definitely feel so privileged, to be able to do this work, live and breathe this work day in, day out. But it's definitely not just me. It's even not just the folks who have health equity, in their job description. I have been, I don't want to say surprised, but I have been so invigorated and energized by just how this has been a bottoms up kind of phenomenon, that we've seen across the company, where teams are taking it upon themselves, to figure out, how to solve for these problems. And I think the conversations, that teams are having right now, because of what's happening, the societal transformations that are happening, around us and in the communities that we live, the commitment we have within our company, to not just, having a diverse workforce, but making sure that the workplace is inclusive and folks feel that they can bring their authentic selves, to work and talk about these issues that are happening in their homes and in their communities, and then get their teams, to work on, what can we do to solve, for this? Because I think that the thing that we need to realize, and why this moment in time is actually a different moment than I felt, prior to this, is that health equity has to be part of our business. It's not something that you do on the side. It's not an add-on. It's not philanthropy. It doesn't just belong to the NGO or CBO sector. It belongs to all of us, and we need to figure out how to embed it, in the work that we do day to day. And I have just been so inspired by all of the different ways that people are thinking about, how their individual work, can make a difference.
Yeah, I want to mention, early on and still to this day, we've been involved with private-public partnership types of arrangements. And especially early on in the pandemic, there was a lot of activity from the private sector. They just were very nimble, very invested, and for example, created tech platforms that were used throughout the state to connect patients to vaccines. So I think that has been critical. And much of the work we've been doing, so yeah, I have been doing in partnership with a tech developer who's ex-IBM, ex-Microsoft, kind of angel investor now, and just wanted to do something. And he approached us and said, "Hey, let's get busy." So we created a platform called Adios COVID, and we continue to work together to this day to do that kind of work. Yeah. And there's been others now that are approaching us and saying, "Hey, we'd like to partner with you. How are you doing this? We want to be involved." It's been great.
Yeah. And I think, part of that, maintaining that momentum is, also being able to understand the impact that we're having. It's great that everybody wants to do something and is doing something, but are we actually having the intended, effect? Sometimes we may be doing more harm, than good, so we also really need to invest in understanding, what the impact, of our work is, and really holding up that mirror, to ourselves, as we do this work.
Absolutely, measuring the outcomes. I love the Adios COVID concept, and it sounds fantastic. And one of my questions was, who do you think is missing from this current discussion about health equity? The name of this session is Going Beyond Diverse Clinical Trials. I think this idea of tech that Leo, you brought up, maybe the tech sector is someone maybe we're not tapping into enough, but who else would you say are people or industries that we should be drawing into this discussion to help move forward?
Do you want? Sure. I to your point, I do think a number of industries and a lot of industries that have been mobilized, and people are realizing that because there are so many social determinants of health, everybody kind of has a role to play, in all of those dominoes that that fall down, as people don't have those equitable outcomes that we're looking for. But I think who's still missing, or who we may be crowding out their voice, are actually the individuals, patients, communities. I fear, to Leo's point, unless we're really investing in them and amplifying them, creating platforms, where we're hearing from them directly, there may be, I think that's where we still have a lot of work to do. I think there's still a lot of talking for, as opposed to elevating and amplifying.
Makes a lot of sense.
So I think there needs to be big disruption. I think we have a really broken healthcare system and public health system right now, underfunded public health, and just fragmented healthcare, and just difficult to navigate, and exclusionary in many different ways. I'm not sure who those disruptors are, but I think we need them, and to be doing things that are different and new. Some people are trying to fill that space, trying to address those gaps in a multi-sectoral way. And I agree with that. We need to have this not just be about healthcare, but about all the needs, social needs that people, housing insecurity and food insecurity that really have impact on, and fundamentally, another one is education. So, I've been involved with the whole issue around workforce diversity, and at its roots, we have a very inequitable education system in the K through 12 part. And, we can see the disparities in our city. We can see them in our county, just north and south. until we start really investing in communities, we're always going to be working around the edges. We're always going to be competing for those few underrepresented students that make it through the system. We need to have many, many more of those students making it through a system that is preparing them for futures in medicine or pharmacy or any of the healthcare fields that we have.
Absolutely. And I think what you just said touches on, so many of these issues that we're discussing are around not only diversity, but equity and location and educational access, all of those things. The name of the session, as I said, was Beyond Clinical Trials, Diverse Clinical Trials. But to speak about clinical trials for a moment here, because you're both very well versed in that topic, how do we rethink clinical trial design to center both diversity and equity, and how are those different?
I think a lot of it comes down to what Leo said about the clinical trial team, where we do clinical trials, that they're powered by a diverse health workforce, because ultimately I do think that issue of trust is enabled when people are able to speak to people and ask questions to people that understand what they may be going through, or specific things that that they need.
I think one thing I like to say is we need representativeness, not just representation. And so I've been involved with a few efforts. It's not uncommon for us, the Latino Center, to have somebody who wants to run a trial approach us and say, we would like to recruit Latinos or Hispanics into our trial. Mm-hmm. And I tell them, well, first of all, that's not a problem we can solve in one day. So what is the history here? But I think more fundamentally, it's the approach. We just don't need to recruit a few Hispanics. We need to understand the breadth and depth of the Hispanic community. And if we want to bring them into research, we need to do it in a way that is, representative. In other words, it's not just convenient sampling of Hispanics. Mm-hmm. So for example, if you recruit, Latinos or Hispanics from Miami, you can't say much about the ones that live in LA. And then even within LA, if you are in West LA, it's very different than if you're in East LA. There's immigration as a factor, acculturation as a factor, language as a factor. There's all these dimensions to the diversity. I think we need a much more holistic, sophisticated view of diversity rather than the simple NIH table. And very sort of, like I said, representatives, but not representative in a sort of sampling sense.
That makes a lot of sense. Well, we're almost wrapping up, so I'm just going to ask one more question, which is a very pointed question, which is, if you had to choose, I'll give you two or three things to really focus on to help promote health equity in the future, and make sure, like we said, it's not just a moment, but it's really a kind of future-proofing all of our lives and all of our businesses. Which are the three things you would focus on? Marianne, I'll start with you.
Well, I think I'll steal from Leo, and that's inclusivity, and making sure that all of us who are doing this work, and all of the teams that need to be doing this work are actually representative of the communities that we want to serve. So apologies, Leo.
It's all good.
And I think that the other thing I would say is data. I do think we need to hold ourselves accountable, but even before that, understanding the problem, understanding the issues. And I think we've seen how powerful a tool data can be for mobilizing action. And sometimes, you do need those stark numbers in front of you, to really, kind of, push people into action.
Great. Leo,
Yeah.
you have 60 seconds. Your end to save the world. Yeah.
We need metrics that are publicly released so that we have accountability. I think we need to invest in our low-income communities. We need to redistribute income. We need to invest in the education system. And we need to do multi-sectoral approaches to health and not just healthcare. And finally, I think presence in the communities that need it most from the healthcare perspective on an ongoing basis.
Wonderful. Thank you both so much. This has been incredible. And we so appreciate your time and all the important work you and your institutions are doing in this effort. So thank you.
Thank you. Thanks for the invitation.
Thank you.
Thank you, Dr. Roshini, Drs. Roshini, Marianne, and Leo for the great discussion about going beyond diverse clinical trials to really talk about diverse clinical trial design, centering health equity, centering inclusion. What a great conversation. And a number of really critical points, insights, and reminders. One, about kind of centering community, and not just in your ask, but in your strategy and how you collaborate. Ensuring that we are, like Dr. Leo said, not just having a representative sample, but really thinking and being thoughtful about who we're inviting to the table and why they're participating in the research. And again, just making sure this is a theme that we continue to hear, resourcing organizations that are punching above their weight to ensure that the resourcing matches their impact. What an important conversation. Thank you to our esteemed panelists. Thank you for those who attended.